Hi, everyone. We're going to tape this lecture today that goes along with your midterm. You have gotten most of this information already in nutrition assessment, so I apologize that there's some repetition. I will probably explain it in a slightly different way, so hopefully after hearing it multiple ways, you'll understand it because it is very important for public health nutrition. So one of the things that we're going to be thinking about today is the U.S. population nutritionally healthy? Of course, the answer to that is it depends on what segment of the population you're looking at. But understanding this and gathering that information and interpreting that information is often a big part of what we do. So today we're going to go over the different types of activities that we use to monitor nutritional health in this country. We're going to review some of the major findings and public health implications. We're going to review the resources available because of the data that has been gathered. And then we're going to also review screening tools, their strengths and limitations. And again, I know that you've heard a lot of this before. I'm going to start out with some simple definitions that you should certainly know. The first one is nutrition assessment. If you don't know that, after taking the class nutrition assessment, I'd be a little bit worried about you. But as a quick review, it is a detailed nutritional history and current dietary intake to identify potential nutritional problems. Assess, right? It's usually the first thing we do, whether we're working with an individual or a population. You probably also know the difference between assessment and screening. Screening is a first-line approach, broad brush, right? Not nearly as detailed. And we use it to identify patients who are already malnourished or at risk of becoming so. Nutrition surveillance is more for research and data collection. It is an approach to collecting data on population health that is done on a regular and repeated basis. And nutrition monitoring is distinct from surveillance and involves intermittent performance and analysis of routine measurements and other observations to detect changes in the health status of a population. So surveillance and monitoring are very similar. The main difference is one is regular and repeated, and the other one is more intermittent. There are many nutrition screening tools out there. I would always encourage you, if you need a screening tool for a certain population, try to find one that is specific to the population that you're interested in screening. We also have a lot that have been shown by research to work. So we want to use evidence-based screening tools. The whole purpose of the Nutrition Screening Initiative was to do the research to make sure our screening tools are identifying those who need further assessment and that we're not missing anybody. So thinking about specificity and sensitivity of our screening tools. Sometimes our screening tools are very specific to a facility, especially facilities that tend to service our highest risk groups. So thinking about hospitals, residential settings, especially for elderly, perinatal services, so places women go before, during, and after they're pregnant, and anyone who works with pediatrics or kids. That first screening, initial screening, should include things that increase risk for nutrition-related diseases, right? That's what we're screening for in our field. So, we're not doing a detailed 24-hour recall. That is for an assessment, but we might be concerned about people's physical ability to obtain and consume food, food tolerances or allergies, a brief diet history, height and weight, alcohol use, medical diagnoses, polypharmacy, food-drug interactions, things that we can ask fairly simply and quickly. Here are some of the groups that were involved in the Nutrition Screening Initiative. Of course, the Academy of Nutrition and Dietetics, American Academy of Family Physicians, and the National Council on Aging. And again, the idea was to come up with really good screening tools for some of our at-risk populations. This slide is talking about some of our screening tools for our elderly residents. They are at high risk for malnutrition. Sorry, I have a little virus on my computer here. So looking at the 9 warning signs of poor nutritional status, you'll remember this as the determine checklist. If you have concerns after using one of these screening tools, we suggest an intervention. That is almost always a referral for a more complete assessment. And of course, this is right up our alley, right? Screening tools are very much used to detect early to try and help people before something becomes more problematic. Here's another example of a quick checklist that came from the Nutrition Screening Initiative. And just appreciate that this is very easy to fill out. It uses simple language. You don't have to have any special expertise to do it. It will quickly come up with a score. And you can see the sources down there to show that it is in fact evidence-based. You may not have heard of some of these others. The PEACH survey. PEACH stands for Parent Eating and Nutrition Assessment for Children with Special Healthcare Needs. It is a screening tool for young children, so birth to 5 years old before they enter into kindergarten, who are at risk for developmental problems. And you can see the PEACH screening tool right here. Again, it's fairly simple. They're mostly yes, no questions, and if you answer yes too many times, then you might have some developmental problems. So think about a young child who may not be gaining enough weight or might be gaining too much weight. Maybe they're at risk for lead poisoning or iron deficiency, the things that we most often see in these younger children. This would help identify that so they can be referred to a registered dietitian. So what's beneficial about screening tools? You can probably think of a couple of things. They're fast, they're easy, they're inexpensive, and hopefully identifying who needs more help. We have to remember that most often these tools are used by staff other than nutrition professionals. So if the people using the screening tool don't know what to do with the information, the tool won't work. And we know, and this is based on a national survey, that high-risk patients are referred to nutrition professionals less than half the time. So our screening tools don't always work because of that reason. One of the problems is, nutrition status isn't straightforward. There are many things that go into one's nutritional status. That's why you have so many courses on this particular subject. So there's no gold standard. So that can make it difficult to both screen and then to have non-nutrition professionals understand what is supposed to happen next. We're going to talk about the national monitoring and surveillance systems in this class. Why do we do this? Well, of course, this is where we get our information from. This is how we plan public health programs and make policies. So it's extremely important that you have a general understanding of where some of this information is coming from. This is obviously a very old source. If you look down there, it's from 1984, but the objectives haven't changed very much, right? We're describing health and nutrition status. We're monitoring for changes. We're providing information on causes of nutrition-related diseases and the relationship between health and nutrition. We're estimating prevalence of diseases, risk factors, and other health conditions, and we're monitoring the nutrition programs and making sure that they're effective and they work, right? This all costs money, both to do the monitoring and surveillance, the federal programs and the other programs that are designed to make people healthier also cost money. So we need to make sure that they work. And of course, this is how we do that. We're going to do a little history lesson here, just so you kind of know when all of this started and the different names of the monitoring and surveillance systems. So the U.S. government has been involved in tracking certain elements of the food supply and food consumption for more than 8 decades. In fact, the first was the USD Household Food Consumption Survey, and that started in the 1930s. So even way back then, right around the Depression actually, the government wanted to know where people eat and where they purchase their food. And it's this type of information, this particular survey, that allowed us to see the information on the graph on the right there. So one of the things that we know about eating habits in this country is that people started eating out more and cooking less. So the total food away from home is that red square, and you can see that increase. Many of you probably remember we were in a recession in this country, 2007 through 2009. That did change people's habits a little bit, and as soon as the economy got better, we started eating out again. So it's always interesting to know that, right? If you're thinking about, making a policy like, should we put calories on menus? Well, we know that people get a lot of food from outside the home, so this helps us, decide if we think that might be effective. Certainly we need more information than just this, but it's part of the whole picture. The first comprehensive nutrition survey was something called the 10-State Nutrition Survey that started in the late 60s. We no longer do the 10-State Nutrition Survey. It is morphed into something else. So the big umbrella organization that oversees all of this data collection is, get ready for it, it's a very long acronym, the National Nutrition Monitoring and Related Research Program. So we have more than 50 different surveillance activities that look at the health and nutrition status of the US population. So clearly, there's an understanding that this is important and it impacts the health of our country. So that's why we have this large umbrella system in place. NNMRRP. I know that you've heard of NHANES. I always like showing the picture of the big semi-trailer there. NHANES is probably the most famous of our surveillance systems. They collect a huge amount of data from about health and nutrition in this country. They collect anthropometric data. They do, collect blood samples for analysis. They collect dietary data. So it is very comprehensive. I'm going to go over some of the major results from the different NHANES surveys. I think it's very interesting to recognize when we started to notice some of our major nutrition problems and then start to think about, well, we've known this since the 70s. What have we done about it? So the first NHANES, NHANES 1, and again, NHANES is National Health and Nutrition Examination Survey, started in the 70s. It included information from people living in the United States from ages 1 to 74. And the major findings was that some people had low iron status. People were consuming generally high-fat diets. Our protein intake was okay. We were starting to see some obesity. And in terms of micronutrients, calcium A and C were problematic. So and again, this is intermittent. So it started up again in 1976, and they collected data for 4 years. This time they included infants, so starting at 6 months years old all the way to 74 again. They were beginning to narrow down who they were most interested in, so they sampled more from young and elderly. They really got more detailed information about some of the problems they found in NHANES 1. And they also noticed some iron deficiency. Sorry about that interruption. We're still talking about NHANES, and we're looking at NHANES 2, and we were talking about iron deficiency. So in any life cycle nutrition lectures or classes, there'll be an emphasis on iron deficiency, and one of the reasons why we know it's a problem is, of course, from NHANES. So not surprisingly, NHANES 2 identified iron deficiency in toddlers as they're transitioning to a diet that includes table food. Sometimes iron is harder for them to get. Women of childbearing age, so think about a woman who is menstruating, so losing blood every month, which will compromise her iron status, and adolescent boys who are having their growth spurts. We also discovered during NHANES 2 that women who are accruing their peak bone mass are not getting enough calcium. NHANES 3 changed a little bit. We started going even younger, so as early as 2 months, with a special emphasis on younger children. Also looking more carefully at our elderly population, especially starting at age 60, and now sampling minorities in our country who might be more at risk. And then in the 80s, we started HHANES. This is the largest, looking at the largest subgroups of Hispanics in the United States living in certain pockets of the country. And we found out that their nutrition issues were very similar to the general population, although we were seeing possibly some stunting in younger children. So what do we do with all of this information? Lots of things. I'm just going to give you a couple of the more famous examples. You've probably heard in many places that obesity rates were increasing very steadily, especially starting in the 80s. And in the past 2 decades, overweight children and teens have doubled. So lots of sort of downstream consequences of that. One of them is that they actually revised the growth charts. So you're all very familiar with growth charts and know that we plot BMI for age, and that's how we identify overweight and obesity. That used to not be something that we even looked at because it wasn't considered a public health problem before NHANES. There used to be lead in gasoline, so if you were pumping gas, you'll probably see somewhere that it's lead-free. Blood work revealed that, especially for younger people where lead is very dangerous, that blood levels were too high. So they identified some of the sources of lead, and one of them was gasoline. So that was a policy change, and everyone was required to remove it. They discovered that folate levels were low, especially in women of childbearing age, which was increasing the risk of neural tube defects. And they started mandatory food fortification with folic acid in the late 90s. We also discovered that there were racial and ethnic disparities in hepatitis B, which is a liver disease. And now there's universal vaccination for all infants and children. So a lot of important public health interventions based on findings from NHANES. All right, so we also want to look at what people are eating. You may ask yourself, well, how well do we eat in this country? So I write here, So it's an interesting question. And if you kind of look at the two pictures, I'm trying to show two different extremes. So the United States does not have a lot of undernutrition, which is good because that's very dangerous. We are generally overweight, under exercise, and beset to some extent with nutrition deficiencies. So we certainly get enough energy on average. There are a few micronutrients that we tend to be low on, especially micronutrients that come from fresh fruits and vegetables, which we're not eating enough of. So malnutrition, this is just a reminder, it comes in many different forms. You know, we immediately tend to jump to undernutrition and thinking about people who might be going through a famine or something else extreme. But you can see malnutrition and obesity, right? Mal just means bad. So you can still have nutrition deficiencies even if someone appears otherwise well nourished. Just kind of a general fact, this is from NHANES 3, and it hasn't changed too much. We get about half of our energy from carbohydrates, 15% from protein, and 33% from fat. So if you look at that data, we're actually meeting the recommendations. Unfortunately, if you dive a little deeper, you know that the carbohydrates, protein, and fat we're getting aren't always from the healthiest sources. This is looking at 10 key nutrients, so both macro and micronutrients. It's a little bit outdated, unfortunately, especially for sodium, which I have circled, has not changed too much. So hopefully you know that the recommendation for daily sodium is less than 2,300 milligrams. So clearly we on average consume more than that. So this is, again, data from NHANES. You know, is this important? Well, I think it is, right? We tell people not to eat more than 2,300 milligrams, but clearly people are, they're actually exceeding that to a great extent. So there's other types of information we can gather and figure out where that sodium is coming from. It is, of course, from all the processed food in our diet. Does it relate to health? Well, of course it does. There's a very high prevalence of hypertension, which we would also know from NHANES. Should we improve this? Well, of course we should. It leads to heart disease, which kills a lot of Americans. So how should we do it? Should we tell people sodium is bad? Should we include recommendations in the dietary guidelines? Should we educate our healthcare providers to talk about it? Should we initiate screening? When should we start taking people's blood pressure? At a very young age. In fact, we have already done all of these things, and guess what? We keep eating a lot of sodium and our blood pressure is too high. So if you kind of think about what the next line of defense or prevention is, you might guess that we'll probably start being stricter on our sodium and maybe even develop some policies that sort of forces people to consume less sodium. We've already seen it in the school lunch program where they at least tried to require that schools keep under 600 milligrams of sodium per meal. That's still very seemingly difficult for school food service to do, and people don't like it. But I think it's an example of maybe what's to come, where we really have to be more aggressive in trying to get the sodium out of our food supply. Here's another example of a survey that we do. The Continuing Survey of Food Intake by Individuals started in the 90s and started in the 80s, and continued on almost to the turn of the century. Not surprisingly, it showed that there's vast changes in food availability and eating behaviors. The graph that I show you there isn't so important in the details. It's just an example of, some of the data that they gather. So we know what types of beans people are eating. That kind of shows you the level of detail that they are interested in. Continuing survey of food intakes doesn't really exist anymore. We still gather that data, but it actually merged with NHANES. So we gather all that data under sort of one umbrella. The report is called What We Eat in America. It is publicly available. And it is the dietary interview. So people do 24-hour recalls in NHANES. Another thing that we're interested in our population is their diet and health knowledge and attitudes. So this was a piggyback of the continuing survey of food intake. They're interested in individuals' diet and health knowledge and attitudes because, of course, that is probably linked to their food choices and nutrient intakes. So these types of questions were asked for adults. Everything from sort of what they know about serving sizes, how they feel about certain health messaging, whether or not they use food labels, behaviors, all the way down to food safety habits that people practice in the home. The Healthy Eating Index you will often see in research. If you think about, trying to get a very quick and dirty snapshot of people's diets, the Healthy Eating Index boils everything down into one number. So it's a summary measure of overall diet quality. So you can see in that table the HEI 2010 Dietary Component Maximum Score. Basically, it is looking at 24-hour recall or other dietary data and giving everyone a score based on how many servings they got. So if someone's getting all their recommended servings of fruit and vegetables and whole grain and dairy, they get the max score. If they're meeting the recommendations for limiting their refined grain, sodium, empty calories, they also get the max score. So once they put that into a single number, they add it all up. So the total population over 2 years old got a Healthy Eating Index score of 59 when we were, of course, ideally 100, which is the max score. So it's just kind of a nice way to summarize someone's overall diet. The Centers for Disease Control also does some of their own surveillance. A reminder, surveillance is done on a regular and repeated basis. They give this data to local and state health agencies, especially agencies that work with our low-income population, children, pregnant women who are enrolled in publicly funded nutrition programs. So as you would guess, WIC is a major target. And they need to know who's using these programs, how effective are they making any difference? So the 4 are listed here. We're going to talk about them in more detail. So the first 2, the Pediatric Nutrition Surveillance System and the Pregnancy Nutrition Surveillance System, look at the prevalence and trends of nutrition-related indicators for low-income children attending federally funded maternal and child health and nutrition programs. So the 2 biggest ones would be WIC and Head Start programs, which is a preschool program for lower-income children. If you're ever interested, it is publicly available data. You can find it on the Massachusetts government website, DPH's Department of Public Health, and you can really get a very comprehensive look at this information. The behavioral risk factor for surveillance system, you've probably seen those graphs of the United States that show the obesity rates. I see them in conferences all of the time. There's a lot of places where we collect BMI information. This is one of them. It is looking at risk behaviors, all 50 states for anyone over the age of 18. They call people and ask them questions, so it is self-reported data, and they use the information to plan public health programs. So the questions are focused on physical activity, diet, habits like tobacco and alcohol use, access to medical care. Are people going in for their mammograms and pap smears and colonoscopies? Do people get flu shots? Anything that would put someone's health at risk. We also do something very similar for our youth. Right now, I think everybody's talking about vaping, so I'm sure that's been added to the YRBSS. This is, again, a little bit outdated, but you can see how they identify what the public health issues are in our younger population. So childhood obesity keeps emerging as being important, bullying, drug abuse, internet safety, child abuse, sexting. So slightly different questions for our younger people, again, focused on anything that might put their mental or physical health at harm. This is a nice summary, again, of how we use this data. Obviously, it's a somewhat expensive undertaking by the US government, but of course it's important. It does have many, many uses. I'm not going to read them all to you. I think they're rather intuitive. Just appreciate that, you know, when we start dumping folic acid into the food supply or changing the food labeling system, chances are one of the reasons why we're doing that is from one of these big studies that gather the data that inform these types of decisions. Another place that we use this information for is to develop things like the dietary guidelines in MyPlate, to help think about what should be a WIC approved food, you know, to kind of think about, you know, should we be offering free mammograms to certain people, that type of thing. So we should, I think, be grateful that we live in a place that values health. We should recognize that we can always make things better and that nothing is perfect, but know that we get a lot of important public health information from these different data collection tools.